now in the 4th week of Hematology Month, and topic for today is Haemostasis and Thrombosis, Integration between Laboratory and Clinical Medicine. We are very fortunate to welcome Dr. Sinari Binti Saleh as chairperson, who is a consultant hematologist, Hospital Raja Perempuan Zainab II, Kelantan. And our speaker today is Dr. Veena Selvaratnam, who is a consultant hematologist and head of Haemostasis Lab of Hospital Ampang. Without further ado, let's welcome Dr. Sinari.
Thank you, Dr. Priscilla, for the opportunity to chair this session. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. Welcome to medical webinar for the hematology of this month. Today, we have the honor to listen to Dr. Veena Selvaratnam, our consultant hematologist from Ampang Hospital. She is very well known to us since 2007. Not surprisingly, and luckily for us, she chose to be the hematologist. And she has proven her method bypassing FRC path and take over the headship of clinical hematology reference by the hospital. In addition to that, she was involved in many studies, including trial, and was published many papers under her name. So without further ado, I would like to invite Dr. Veena to give her insight onto this topic that we mentioned by our host today. Please welcome Dr. Veena.
Thank you very much, Dr. Sinari, for the very kind introduction. So I've been given the task today to speak to you all on hemostasis and thrombosis, the integration between laboratory and clinical medicine. I don't really have very much to say about, I haven't really, basically I will just speak about the coagulation testing as well as the clinical presentation. So this is a little bit of the lecture outline for today. Firstly, I'll speak to you all about a little bit on understanding hemostasis and the whole mechanism of bleeding and clotting. Talk a little bit on the laboratory parameters and the coagulation cascade, and then subsequently go on to give you all some clinical picture with some laboratory findings so that you can tie the clinical picture with the laboratory findings via case presentations, and finally end with some take-home message. So I think as hematologists, we really cannot emphasize more, how important understanding hemostasis is, okay? And we do know that, essentially, this is a state of equilibrium, and under normal condition, the blood is maintained in its fluid state when there is intact vascular system. So all these components in your blood vessels are at equilibrium. You have your coagulation proteins, your platelets, the vessel needs to be intact, and you also have fibrinolysis inhibitors that are present so that you keep the blood in a fluid state and at equilibrium. Now, what happens when there's an injury, right? So there are a few phases that are involved. You have the vessel phase, the platelet phase, the coagulation phase, the fibrinolytic phase. During the first phase, which is a vessel phase, immediately after you have an injury, there's vasoconstriction and retraction of blood vessels. And there's also, as a result of that, there's a build-up of extravascular pressure by blood loss from the cut vessel. So this actually, in a way, reduces the bleeding rate of the patient post-injury, right? And then the vessel phase is activated, whereby the damaged blood vessels, so you have the exposed tissue factor, which then binds to collagen and von Willebrand, and therefore you have the initial clot or the primary hemostasis that takes place. So platelets are attracted to that area when tissue factor binds the collagen, and then eventually, the platelets are activated and you form the initial or the primary clot, right? After which the secondary hemostasis occurs, whereby during the secondary phase, there is activation of the coagulation factors per se, all right? And this, the initial reaction that happens there is because the tissue factor, it binds to factor 7, that actually then activates factor 7A, triggers 10A, and then you have a production, you have downwards your coagulation cascade, you have initial burst, and then subsequently you have a secondary thrombin generation that then activates your intrinsic pathway, and that's where your factor 8 and all that comes in, gets activated, and you have a good platelet, a stable clot formation, sorry. So there's fibrin, during the thrombin generation, there's fibrin accumulation, you have a really stable clot, right? So if this process doesn't stop, basically it's a vicious cycle. If it doesn't stop, then the whole vessel will eventually clog up. So therefore, you need some sort of check and balance mechanism whereby you have the fibrinolytic phase. So this phase ensures that your clotting and anti-clotting factors are at equilibrium, and therefore the whole vessel doesn't clog up subsequently. Okay, so this is also important to prevent complications in terms of thrombosis. So if you have problems with your coagulation factors, of course you have problem forming the blood clots to begin with, and if you have problem with the fibrinolytic phase, in the sense that the anticoagulation factors within the body, if it's not functioning, then you have a thrombotic state, and that's where you have problems. Okay, so in order to ensure normal hemostasis, you need to have a good an intact vessel wall. There should be adequate number and function of platelets, adequate levels of the coagulation factors, as well as the proper function of the fibrinolytic pathway, and all this is kept at an equilibrium. If there is an imbalance in the sense that if your procoagulation factors becomes higher, or there's a problem with fibrinolysis, then you are put at a hypercoagulable state. If there is deficient coagulation factors, then you will be put at a bleeding state. So if this equilibrium is affected, then you will have problems, right? Now, moving on to the laboratory test that we routinely do. We always do something called coagulation profiling, or we say the coagulation screen. And we all know that coagulation profile, or what we do routinely in our centers or hospital, is that we do a PT, APTT. Some places will do a thrombin time as well as fibrinogen. Of course, I think this is not widely available, but routinely, definitely most centers at least have PT, APTT. And then we do a full blood count to look at platelets. So all these are important to determine whether the patient, determine the coagulation profile, or the profile of your patient per se, right? And what does this coagulation profile tells you? So this is looking at the coagulation cascade, right? So you see your APTT is, okay, so basically this is your coagulation cascade. This is your extrinsic pathway, which starts at, is usually initiated by factor 7. When exposed to tissue factor, it gets activated and down this way. So it activates factor 10. Factor 10 in combination with factor 5 will then activate prothrombin, and then eventually fibrinogen converts to fibrin. So this is your extrinsic pathway. When you have a thrombin burst, subsequently your intrinsic pathway becomes activated. And of course, this is where the other factors that are involved. So you have factor 12, 11, 10, 9, 12, 11, 9, and 8. And then subsequently your common pathways, or your factor 10, 5, and 2, and as well as your fibrinogen. All right. So the PT is usually affected if you have problems with the extrinsic pathway. APTT is a problem when, or it's affected when you have problems with the intrinsic pathway. And of course, the thrombin time basically shows you the integrity of your fibrinogen. All right. So of course, anything down this line, PT will be a problem. Anything down this line, APTT will be affected. So what happens if you have an isolated prolonged PT? You see, in isolate, the PT is essentially depicts your extrinsic pathway, whereby your tissue factor and your factor 7. So almost always, if you have an isolated prolonged PT, it is due to a factor 7 deficiency. All right, back to your, that's based on your coagulation cascade. How about having an isolated prolonged APTT? So as you can see, these are all the other factors that are involved or interferes with your APTT, right? So you can have factor deficiencies of factor 8, 9, 11, 12, as well as the contact factor deficiencies. Or it could also be prolonged because of an inhibitor, either a non-specific inhibitor or a specific inhibitor, right? So something that is interfering with your test in vitro. How about if you have both prolonged APT and APTT prolonged? So basically all of these are affected, and therefore your differential diagnosis would be either a common factor deficiency, which is 2, 10, or 5, or multiple factor deficiencies like warfarin. So you mean something that involves both the extrinsic as well as the intrinsic pathway. So mainly it's the common factor deficiency, but if it involves both sides of the cascade, then you will have both prolonged PT and APTT. How about prolonged thrombin time? Thrombin time is essentially the time taken for fibrinogen to convert to fibrin. And most often than not, it is just dependent on your fibrinogen per se. But having said that, it could also be due to the presence of an inhibitor, either direct or indirect, low fibrinogen level, or dysfibrinogenemia. So essentially, mainly fibrinogen, whatever that affects the fibrinogen, the content of your fibrinogen. However, there are non-specific conditions whereby your thrombin time can be prolonged, and this is in the presence of hypoalbuminemia or elevated FDP. So FDPs also acts as like an inhibitor to your fibrinogen in vitro. All right, and if you have everything prolonged, meaning that your PT, APTT, as well as your thrombin time is prolonged, then most often than not, it is because of an inhibitor of thrombin, or if you are in consumptive coagulopathy, whereby you've used up everything per se, or if it is failure of synthesis. Usually when you have a patient with liver dysfunction or very severe liver dysfunction, by this stage, probably they're already in chart C. All right. So basically, a coagulation screen or a coagulation test basically tells you that there is something there, there's something wrong, perhaps, right? But whether it is a significant thing or not, we really do not know. Can it identify your patient, whether the patient is a bleeder or a clotter? Well, does it tell you? So how do you identify a bleeder or a clotter? Essentially, you can only identify that is basically by getting a good there is no test or a hemostatic test actually at this point in time to tell you whether the patient is a bleeder or a clotter based on the basic or the routine coagulation testings that we have. And in fact, the best way to determine whether your patient is a bleeder is a good bleeding history, right? That is the best screening test that one can have or one can offer to your patient. So if you get a good bleeding history, then you would be able to say whether your patient is a bleeder or not. Okay, and what is a significant bleeding history? Basically, this is in reference to the ISTH BAT score, and you can look it up if you Google the ISTH BAT or the bleeding assessment tool scoring. Okay, so these are significant bleeding histories that you can look for in your patients. If you have epistaxis, what do you call this, trivial bruising, very prolonged bleeding that it takes long time to heal or stop, spontaneous GI bleeding significant enough for you to get anemia, if you have significant menorrhagia, or if you have recurrent dental bleeds. These are all quite significant. Okay, so what are the questions that you need to ask? Once again, if you refer to the BAT, ISTH BAT score, you will be able to know what questions to ask. So I suppose you need to ask whether there's history of prolonged and frequent bleeds, whether it's single or multiple sites, does the bruising occur with injury or spontaneously. Okay, if there's a prolonged bleeding after dental injury, and prolonged bleeding after a dental injury or surgery or whatever is usually days, not immediately. It takes like a few hours to stop, but mainly more of days to stop, right? So that's very significant. If you have been stressed before, right? whether based on your previous history of surgery and stuff like that, whether there's any significant bleeding, whether there's history of menorrhagia, family history, as well as medication intake. So that's also important. Medication must be something that you should not forget to ask. Okay. So what are the types of bleeding? Usually there's bleeding, patient can complain of bleeding, which is immediate bleeding. And usually if there's significant bleeding immediately post-trauma, then usually it indicates defects in the primary hemostasis, usually either some platelet dysfunction, or if there's a vascular abnormality or some vessel wall abnormality. However, if you have delayed bleeding, that means you are able to secure immediate hemostasis but have re-bleeding later on, that usually indicates that you have problems or patients have problems with secondary hemostasis, all right? And that usually refers to coagulation factor deficiencies, or there's a problem with fibrinolysis. All right, so this, once again, I cannot stress how important this is. This bleeding assessment tool is very, very important. It actually tells you whether your patient is a bleeder or not. And there is a scoring system. I'm not sure whether there's an app for it now, but this is something that you can actually ask your patients and get a score before surgery or whatever to determine whether your patient is a bleeder or not. All right, and therefore a good bleeding history is still the best screening test for a bleeding disorder. So now let's move on to what do you call this? A case presentation on how you marry your clinical history and also the blood test that you get. Okay, so case one is a 58-year-old gentleman admitted for congestive cardiac failure. He was noted to have a LA thrombus on echocardiogram. He had a PT of 35 seconds and INR of 2.5 and APTT of 30 seconds. And the PT repeated a few times is still prolonged. Okay, so before I go on any further, I'd like to emphasize here that when we mention INR, it actually refers to PT ratio, right? So PT ratio. So whenever when you try and give a history or whatever, and you use INR to explain whether the INR is prolonged or what, from a hematologist's point of view, INR only makes a lot of sense if the patient is on warfarin. Other than that, when you look at a coagulation profile, you are meant to mention whether it is PT and APTT. And you cannot just do PT isolated and APTT isolated. I just want to say that, because every time when we say what is the coagulation profile, most people will say, oh, the patient's INR is 1.8 or 1.5 or whatever. But by right, you should mention what the PT is rather than the INR, unless the patient is on warfarin. All right. Now back to the case. So basically, repeated PT still prolonged. So basically, then they presume that this gentleman had liver disease, and or the patient is on warfarin and they didn't do anything, right? So congestive cardiac failure with LA thrombus, because the PT was prolonged, they did not give this gentleman anticoagulation. So it was not started in view of prolonged PT and hence presumed auto-anticoagulated. Unfortunately, subsequently, he developed a cardiac arrest and died. And then eventually they sent the test to a hemostasis lab for further testing. So now moving back, right, this patient had a prolonged this person seconds, right? So then further investigation done showed that actually the reason for his PT to be prolonged was actually a factor 7 deficiency. So and all other levels prolonged PT in the absence any other abnormalities is almost always due to a factor 7 deficiency. And a factor 7 deficiency, sometimes, if it is not low enough, it doesn't cause much problems. And in all honesty, this gentleman should have been anticoagulated after probably discussing with the hematologist. All right. Okay. So moving to case number 2, this is a 10-year-old boy with giving a recurrent history of gum bleeding and chronic tonsillitis. He was planned for a tonsillectomy because this tonsillitis, tonsils were troubling him. He got recurrent tonsillitis and eventually they decided to take it off. Okay. So as the routine practice, the PT, APTT, and the FVC was done, and it was within normal range. So since the platelet count was normal and the coagulation profile so-called was normal, though he gave a significant history stating that he had recurrent gum bleedings, he was reassured and proceeded with tonsillectomy. However, during surgery, there was some excessive bleeding, but it was controlled with local measures. They cauterized the tonsil bed and it stopped bleeding. They sent him back to the ward, and unfortunately, 2 hours later, postoperatively, he bled again, all right, with further significant bleeding, right? So they had to take him back to OT and then more cauterization done. He bled enough for him to for his hemoglobin to drop from 10 to 8. And therefore, 2 pints of Hexal and 2 units of FFP was transfused and bleeding was subsequently controlled. And a repeat APTT the following day was obviously normal. It started off to be normal and it was normal the next day. Then after which they referred him to a hematologist. So as usual, as routinely, usually we get a bleeding history. So the bleeding history was taken and it was noted that he actually had easy bruising. He had recurrent epistaxis and recurrent gum bleeding. So he is actually shouting out to you that, hey, I am a bleeder, right? His mother also had menorrhagia and easy bruising. This was the FBC. The FBC was normal. PT was 13 seconds, which is normal, and APTT was 40 seconds, which is also normal, right? And then, of course, because there is significant bleeding history, we then proceeded to do a von Willebrand assay, and as suspected, he had low factor VIII level and low von Willebrand level, so at 20%. So the diagnosis of type 1 von Willebrand disease was made for this gentleman. So a limited investigation of a patient with significant bleeding history, he has presented with quite a significant bleeding history. He said he's got recurrent gum bleeding, recurrent bruising, and so on and so forth. Because the coagulation profile was normal, it is not an appropriate thing to do, right? By right, he should have been investigated as compared to extensively investigating a patient with no bleeding history but has an abnormal coagulation profile. So it is important to bear this in mind. Okay, so your patient always tells you the right story, and then you marry the blood investigation results with the history the patient tells you. So a little bit of facts about the coagulation screen. Essentially, it is practical, but it's not physiological. So what you see, because it's an in vitro test, right? It's not an in vivo test. So it's not physiological, but it's practical. So you can get some information, but you may not get all information. It has got limited sensitivity and specificity, and the test, and in all honesty, it tests a very limited proportion of the hemostasis. So hemostasis is a complex thingy, and what you get from your coagulation profile is actually just a part of it. Because nowadays, with technology, we have global hemostatic assays, so that's a different ballgame altogether. But it's not really widely available, so we can't really talk very much about it. Maybe that might be the future, and this may change, right? This concept might change, right? So always bear in mind that a normal screening test results in occasionally gives you a false sense of security, especially so in a case like this, right? And you need to understand that when your coagulation profile is normal, you can occasionally miss these diseases. Okay, you can miss very mild factor deficiencies. Diseases like von Willebrand disease can be missed. Factor 13 deficiency gives you a completely normal coagulation profile, but they're actually bleeders. Some platelet disorders, excessive fibrinolysis, if you have vessel wall disorders or metabolic disorders, all these are not picked up on your routine coagulation screen. Of course, uremia you can pick up with the renal function, but if you just do your coagulation profile and platelet, you won't be able to pick up some of these, right? So now moving on to case number 3, a 45-year-old man admitted for ureteric colic. Ultrasound actually showed a large stone with hydronephrosis causing obstruction, and he was planned for stenting. PT, APTT was sent, but he did not have any bleeding history. So APTT showed that it was 98 seconds and the platelets was 12 seconds. The procedure was cancelled because the APTT was very, very prolonged. He was then referred to a hematologist, and the mixing test actually was corrected. And therefore, because he did not give a bleeding history, we then proceeded with a factor 12 assay, and it was 15%. So these are some disturbances in the coagulation profile. So though factor 12 is low in this gentleman, it usually doesn't cause bleeding. So we then advise that, okay, it's a factor 12 deficiency, routinely seen in actually patients with renal impairment or end-stage renal failure, but it doesn't cause any bleeding because there's no bleeding history, and you can actually go ahead and do your procedure without any complications. Okay, so factor 12 deficiency is not associated with bleeding or clotting. It is required for contact activation for in vitro laboratory testing. Okay, so it's in a way a laboratory nuisance, and unnecessary investigation may be seen in a patient with no bleeding history. But having said that, it is good to investigate because all isolated coagulation abnormalities has to be investigated because you could miss an inhibitor. So yes, you still need to investigate, but perhaps you don't need to cancel too much your surgery or whatever. You just need to treat the patient based on, after doing a certain screening test. Okay. So moving on to case number 4, a 1-year-old boy presented with prolonged gum bleeding post-fall, had previous history of bruising. He had a history of cathal hematoma during birth. His maternal grandfather had easy bruising and history of prolonged bleeding as well post-surgery, and has an elder brother and sister who are normal. All right, so what do you think this boy has, and how would you investigate him? So the salient points here are he's a male, he's got significant bleeding history, as well as birth history that says bleeding, right? Early presentation in life, and also had a family history. So family history because his maternal grandfather had easy bruising. So there's a possibility that his mother may have carried something that is X-linked related. All right, so APTT done showed, it was prolonged at 60 seconds, and PT was normal. And therefore, a factor 8 assay, confirmed that this boy had hemophilia. Now, APTT can be both hemophilia A and hemophilia B, yeah? So prolonged APTT. So you need to do both factor 8 and factor 9 assay to determine what sort of hemophilia this boy has, right? Okay. Case number 5, a 63-year-old lady, known pemphigus for 1 year, admitted for fever, with history of bleeding from the lesions, and for 3 months requiring blood transfusions, right? So that means this is a significant bleeder. She was hypotensive. Hemoglobin when she came in was 3.3. Platelets, PT was 21 seconds, and APTT more than 180. So here actually both the PT and the APTT both are prolonged, but the APTT is much more prolonged than the PT. Probably because she bled so much that the hemoglobin was so low, so there was some degree of consumption. Right? The same patient eventually was transfused 4 pints of Paxil, 4 units of FFP before femoral insertion. No other investigations was done, just transfused FFP. And unfortunately, post-femoral line insertion developed a very large hematoma. Then the HP dropped from 8 to 3 grams again, right? And then eventually, because she bled so much, they gave her 2 doses of recombinant factor 7A, and eventually a factor 8 was done. A factor 8 assay was 1%, and inhibitor to factor 8 was present at 100 BU. So basically, this was a case of acquired hemophilia, which was initially not investigated, but then subsequently, because she developed significant bleeding, she was investigated and diagnosed to have acquired hemophilia. So cases like this, a bleeder telling you that I'm a bleeder, I have abnormal coagulation profile, you must investigate. Okay, somewhat the same case, prolonged APTT more than 100 seconds, not investigated, went in, did a cardiac catheterization, and then patient bled so much that eventually, before the diagnosis was made, and then complicated by a wound that was infected and required a lot of problems. All right. So another case, excision of a hematoma, where the patient presented with abnormal coagulation profile as well, and a bleeder, PT of 13 seconds, APTT of 120 seconds. He was transfused 4 units of FFP before op without investigation, and then eventually bled significantly. All right. So though we do say that there are some isolated prolonged APTT that are not significant, but if the patient gives you a bleeding history, you definitely must investigate it, right? Because it could be a lot of conditions, like you see here, factor 8 deficiency, or severe von Willebrand deficiency, factor 9 deficiency, 11 deficiency, 12 deficiency, which is usually a nuisance, but at least it's nice to know that it's you have made the diagnosis and the patient is safe. And of course, it can be due to a non-specific inhibitor like a lupus anticoagulant, or a specific inhibitor to factor 8. So you need to investigate. So all isolated prolonged APTT that is not, when you have sorry, I missed one slide here, or one step here. So whenever you have a patient with an isolated prolonged APTT, you cannot just transfuse, or you cannot just assume that it is not a problem. You need to investigate. And how do you investigate that? You need to do something called a mixing test. And if your mixing test and if your mixing test is corrected, then you need to look for factor deficiencies. If you have a mixing test that is not corrected, then the differential diagnosis would be either an acquired factor VIII inhibitor or acquired hemophilia A, or it could be an antiphospholipid syndrome. So the difference between these two is that the first one will bleed and will bleed a lot, will bleed like hell, whereas the second one are non-bleeders. Okay, antiphospholipid syndrome is in fact they are clotters. So all isolated or disproportionately prolonged clotting tests must be investigated, and you need to do a correlation with the patient's clinical history and to determine whether the patient is a bleeder or a non-bleeder. Okay, and please do not transfuse the patients without doing an investigation, because inappropriate blood transfusion or blood or product transfusion shouldn't be the standard practice as depicted in the case presentations prior to this. Okay, so the next time you decide to transfuse a patient like this, if you see abnormal coagulation like that, you have to stop, think, and ask yourself, is it really necessary? Have you determined what the cause is of the prolonged PT or APTT is? And if you haven't decided, then you need to determine what the cause is. And if you have a problem, then you need to call for help. Okay. Okay, I think you can skip this. All right. That is essentially mainly for surgeons. So I didn't talk very much about clotting per se, but there's nothing really very much from your coagulation profile that would actually determine whether the patient is a clotter or not. So clotting tests, as in terms of further investigation of patients who develop thrombosis, right? One thing that we have to be very clear is that the only thing that will come apparent in your routine coagulation testing is your lupus anticoagulant. So lupus anticoagulant, if you test your coagulation profile using a APTT or a LA-sensitive APTT testing, then the APTT will be prolonged and there'll be an isolated prolongation, and that's almost always, or most often than not, will be a lupus anticoagulant. And as far as thrombophilia screening is concerned, we don't routinely do a whole battery of tests. We need to determine whether the thrombophilia or the thrombosis occurs at a very young age or an older age. So significant protein C, protein S deficiency, and antithrombin deficiency that is present due to congenital problems are usually very young. They present very young. Or like if you have severe protein C or protein S deficiency, even at birth or at childhood, infancy itself, you would have had problems. So if they come on much later in life, then the deficiency is actually not significant. So I think the more important thing in terms of adulthood is your lupus anticoagulant and your acquired thrombophilias per se. So lupus anticoagulant is one of the most common things that is a problem in adulthood. Okay, so finally, my take-home messages: blood essentially is a precious commodity, so please use it judiciously. Please do not transfuse your patients unnecessarily without doing proper investigation. It is not free, so do not do routine coagulation testing. Instead, do routine bleeding score assessment. You always have to base your test results back to your patient's clinical history. So that's actually very, very important. And always investigate an abnormal coagulation result. I think when you do a coagulation screening, if you already do it, then, and if it turns out to be abnormal, you have to investigate. You cannot just transfuse and say, okay, I've transfused, so it should be corrected, I'm happy with it. Okay, so do not blindly transfuse and be happy with that. Okay, with that, I would end my presentation today. And I'm happy to answer any questions.
Thank you, Dr. Vina. It was fantastic as usual, and today is not an exception. I'd like to see a few on the chat there. We've got any questions? It seems that there's no question from the floor. Okay, so I would like to ask a question of myself, Dr. Vina, if you don't mind. Dr. Vina?
Yes, sure, Dr. Sinari.
Yeah, okay. A couple of days ago, we got one particular incident whereby a lady who got admitted, and then one of the managing doctor informed us that the APTT was prolonged, and she would like to ask for the mixing study, and then she called the lab for the mixing study. And somehow the lab said that it should be done 4 days later because the patient was transfused FFP. What is your comment to that?
Sorry, I think you have to investigate. There's no such thing as do it later, 4 days later, because FFP was transfused. The fact that you have transfused FFP and still it is prolonged means that it is problematic, right? Essentially, there's something there that has not been corrected. So I think
Yes.
You have to still investigate, because there's no way for you to know what the cause is. So I would say you will still need to investigate and do that mixing test, bearing in mind that yes, the patient was transfused, and if it is not prolonged after, you have to then give a result with some caveats to say, okay, maybe it has been corrected or something like that. But
yes,
you need to do the test, because otherwise
yes.
you won't know.
Yes, very true. I think there is the problem on the clinical side, because to be fair to the lab, okay, they don't know the patient situation. So it is very important for us to emphasize to the lab state that the patient have a very huge hematoma, it's almost like multiple site of hematoma. And then if the case was referred to the expert, okay, they will say this one is an acquired inhibitor, And then, so they will proceed straight away to the mixing study straight away to find the inhibitor level, as I such not. But the thing is that will not convey the message to the lab, So it's very important that they are clinician, okay, we have to emphasize to the lab that we need a test so that they will reject us, okay?
Yeah, even if they reject, you have to force them and tell them, please do it. I don't care. I want it done, Che.
Yeah, very true, very true. So we need someone who can speak, people who can convey the message. Okay, Vina, I found a lot of questions here, which I didn't see earlier, okay, from one of the attendee, okay. An elderly female with underlying atrial fibrillation on dabigatran admitted for CAP in sepsis and hematuria. Noted INR is high, 5 to 6. So the fellow asked, is there any role of either rusizumab or such a high INR is due to sepsis or coagulopathy?
Okay, so with dabigatran is a direct thrombin inhibitor. So when you have a direct thrombin inhibitor, there is a possibility that your PT, APTT will be prolonged, usually the PT more than the APTT, if I remember correctly, and therefore your INR is prolonged. So once again, I would like to emphasize that INR is meant to be used only for warfarin therapy. So I would still stick to PT and APTT. But having said that, the role of reversal or not will all depend on your patient. Now, if the patient is bleeding and significantly bleeding, and you think that the dabigatran is there and it's causing that coagulopathy that's causing the patient to bleed, then yes, you give idarucizumab. But most often than not, if the kidney functions are good, patient there's no renal impairment, and if the patient is not bleeding out or there's no active bleeding per se, that you can probably wait. So it all depends on the clinical presentation of the patient at that point in time. I recently had a patient who came in with GI bleed, fresh PR bleed, also on dabigatran, and also bear in mind that the more accurate marker for this or reflection for this is actually your dilute thrombin time or your thrombin time, because it is a direct thrombin inhibitor. So if you can do a thrombin time that would be more, or a dilute thrombin time will be more accurate. But having said that, because the bleed was not very significant, the hemoglobin was stable, patient was hemodynamically stable, there was no reversal agent that was required. And eventually, after about 4 or 5 days, after day 2, actually the PT and the APTT normalized, and then eventually the thrombin time normalized about 3 or 4 days later, and we didn't need to do anything. So it all depends on the patient and the clinical presentation at that point in time, whether to be or not to be. It depends on patient. It is not a number based, it is a patient based decision that you have to make.
Yeah. So in regard to this question, I have a query of my own. The INR is 5 to 6, so is it possible for us to consider vitamin K, the cheaper version, rather than going for the idarucizumab, since we know that the dabigatran won't cause prolonged INR?
So it depends on how urgent, I mean, as in you can give vitamin K if you think that the patient has got liver dysfunction at the same time. So vitamin K in sepsis is not a indication you can actually give it.
Right.
But yeah. So moving on, but whether or not it's going to correct the prolonged PT, it may not correct the prolonged PT because the pathophysiology is a bit different. Maybe there's a question on anticoagulation in type 2 developed alcoholism postpartum.
So okay.
Yeah. So basically,
next question.
Yeah. I've already moved on to the next question.
Yeah. Okay. So you answered that, right?
Yeah. No, I haven't answered that yet. So I'm going to answer now. So basically, in a situation like this, the only way I can think about is to block and replace. I mean, replace and treat. So basically, if the patient has got von Willebrand disease type 2, you give the factors to correct your recough, and then you anticoagulate the patient as how you would anticoagulate normally. So that's what we would do for our hemophilia patients as well. If a hemophilia patient comes in with an MI, you correct the factor 8 levels to the normal levels, anything on the 50%. And then you treat the patient like how you would treat any other patients with an MI. So that's what we really need to do in this situation.
Yeah. I think the next question also the same thing. I think the patient who are bleeding and all develop bilateral PE, so almost the same thing. Okay.
Yeah.
So we go to the next question, Vina. Okay.
Yeah.
Hi, doctor. Can you talk a bit on SCT and the RVTT screening? What is the significance of the test in patients with weekly presence LA?
What is the significance? So DRVVT is actually a very sensitive test for lupus anticoagulant. You can actually pick up even sometimes weak LA using your DRVVT screening per se. Now, the question is, when we are talking about clinically, how significant is this weak LA clinically? I mean, the fact that you have done a DRVVT screen probably because the patient has developed a thrombosis or a clot, right? And I think from as physicians, I think we need to always determine how significant is your test result to your patient. If a patient has a weak LA but out of thrombosis, meaning that the patient has got no clots, then it doesn't mean anything, right? But because we do know that LA is an antibody, and sometimes you have LA in sepsis. LA sometimes comes on maybe even in pregnancy. I mean, it is very non-specific. Having said that, if it is associated with thrombosis, then you have to treat, and that is significant for your patient. But if the patient doesn't have a clot, then it is non-significant. I don't know whether this answers the question, but I think it's all about a laboratory and clinical correlation. So that's why I say clinical history, clinical presentation is very important. You need to determine what your clinical picture of the patient is, and then you order the test. Not do the test and make the test determine what the patient is. That is the wrong way of doing things. So usually you don't order everything under the sun. What are you looking at? You need to know what you're looking for from your history, and then have some sort of differential diagnosis and use your investigation results to determine or to see whether your differential to pick out which is the diagnosis from your differential diagnosis. I think that's more important than anything else.
Okay, then we go to the next question. Do we routinely send for factor 7 deficiency for patient with isolated prolonged PT? Any specific indication on timing to send a test?
So if you have an isolated prolonged PT, then as I mentioned earlier, any isolated prolonged test, you need to do a mixing test. So do a mixing test first. Your mixing test is corrected, then you send your usually when your mixing test is corrected, it's usually due to a factor deficiency. So if you do, and then to determine that factor deficiency, then you need to do factor levels. And most often than not, an isolated prolonged PT is due to a factor 7 deficiency. If your mixing test is not corrected, then very strong lupus can also cause PT prolongation. So it could be a lupus anticoagulant. So most importantly, it's a mixing test. So if your mixing test is corrected, then yes, you do a factor 7 level. If your mixing test is not corrected, then it is an inhibitor. Then you have to look for that inhibitor, and most often than not, it could be a very strong lupus. And in that situation, most often than not, your APTT will also be prolonged. Now, when do you send for factor 7? So you need to know that the half-life of factor 7 is very, very short. So it has to be a very fresh sample. That sample, once it reaches your lab, it has to be spun, frozen, and sent frozen to whichever lab that is going to do your factor 7 level. It's only 2 hours, your factor 7 half-life. So that is very, very, very important that you actually get a very fresh sample. If possible, get your patient to the lab, do your blood taking there, spin it immediately, freeze it. So that will be the most accurate factor 7 level. If you take it in the ward, let it sit for 4 hours, it's already dropped by 50%.
Yeah, yeah. I think the person who asked the question know the answer already, Vina, okay?
Oh,
because the question is very specific. Okay. Okay, we go to the last question so far. Can we send thrombophilia screening for patients who are admitted for thrombotic event and on anticoagulant? This is a very famous question, actually, because we got questions all the time about this.
So I always ask myself, is it going to change your management at any time?
No.
So if it's not going to change your management, why send? That is the big question. You've got acute thrombosis. Now, are you going to stop anticoagulation if your lupus comes back as negative or your protein C, protein S is normal? No, you're not going to. So why do it at the point of thrombotic event? There is no indication to. The best time to do it is when you decide to stop. If you decide to stop, and the patient doesn't want to continue anticoagulation for whatever reason, and you need to risk stratify the patient, then you do. Otherwise, I don't see the necessity from a clinical point of view to do this thrombophilia screening at the point of acute thrombosis. It is not going to change your management. You are not going to stop anticoagulation for the patient. Of course, except maybe for very rare situations where you think the patient may have antithrombin deficiency, but even then I wouldn't. And you want to give replacement therapy, but it doesn't hold any water in our country because we do not have antithrombin replacement. So I wouldn't do thrombophilia screening at the point of thrombosis.
Okay, I think everyone is clear about the thrombophilia screening during the acute thrombotic event. Okay, we have another questions coming up. Okay, I have encountered patients like case 1 presented by doctor. Is there any safe range of PT to start anticoagulant? Because most of the time we are afraid to start due to prolonged INR. Yes, this one also I would have asked Vina as well. Thank you for asking.
Okay, so the patient has got a blood clot. You need to anticoagulate. You don't want to give warfarin because you cannot monitor INR. You give low molecular heparin dulu while you investigate what is the cause of prolonged PT. So there's a clot there. There's always an urgency to treat, because I always say that clots probably kill you faster than bleed. Bleeding you can see, clot you cannot see. Once that clot goes into the brain or goes somewhere, you will die. So to me, I feel that starting anticoagulation, especially things like low molecular weight heparin, is very safe in this time and age. If you do not want to start treatment dose, you can always start prophylactic dose, but urgently investigate the cause of prolonged PT. Meaning that you refer to the right people and say, look, I have this patient. Can you please help me investigate why is the PT isolated prolonged? I mean, to do a mixing test in the lab, it shouldn't be difficult. It should be done in almost all hospitals. It's not a difficult test to do. So investigate, but treat. It's not a problem to treat.
Okay, Vina, the questions keep on coming. Okay, about sending factor investigation if factor 7 and 8 is normal and LA negative.
Okay. This person tak dengar or maybe tak understand. Factor 7 is PT, not APTT, is 9 and 10. Okay. And then LA is negative. Okay. So what about sending factor 12? I suppose you can send, but you need to be clear in your mind is that prolonged APTT, have you done a mixing test or not? You must do a mixing test first. If your mixing test is corrected, you think it's factor deficiency, you have done your routine factors, but it is not there, 9 and 10 is not there, because routinely 9 and 10 is available in supposedly all state hospitals, then yes, you can send for factor 12. But if your APTT is not corrected, then only you do a lupus. Not APTT prolonged, you terus buat your factor 9 and LA like that. Where is your mixing test in between? You must do a mixing test as well. I think that's very, very important. Step by step, you follow step. If you follow steps, ikut turutan, most likely you won't miss anything. I think that's important.
I think it's about all, Vina. We have no more questions. Okay. And I think this is very great, Vina, for having a very good discussion for today. Okay. So any last message you want to give to our attendee for today, Vina, before we sign off?
I think I would always say that your patient is always the best investigation. If your patient tells you something, take that seriously and investigate based on history. So history is the most important thing. Then laboratory is just to confirm your clinical suspicion based on history. So I think we shouldn't be very obsessed with doing investigations and testing and stuff like that. We should always be more obsessed to get a good clinical history and treat your patient based on the patient, not based on numbers, not based on lab investigation. I hope that is very, very important.
Yeah.
And don't transfuse simply just to correct numbers. Hemoglobin 7, transfuse 3 pints of packed cell to make it 10. APTT 100, transfuse 4 units of FFP to make it what? I also don't know. You don't treat the patient based on numbers. You treat the patient based on the patient. So I think that's very, very important.
Yeah, thank you so much, Vina. I think that one of the most important things that we can learn today is that how to integrate between lab and also clinical judgment, rather than doing tests simply and then just for the sake of doing tests. And then at the end of the day, we even don't even know how to interpret the test. But the most important thing is that we have to have a communication between lab and a clinician so that we don't misuse of things. So even myself, also most of the time, I will ask the lab, will ask advice for them, what can be done at this point of time, but if not, that we can wait for another 3 to 3 months to be done. Okay, folks, thank you so much for listening to us. Anything else, Vina?
One more last thing. One more last thing. We need to know that all this is money. It's very expensive.
Yes,
testing is very expensive. Blood is very expensive. We cannot simply do. Though we don't see it, it's a lot of money. So I think we need to be very mindful of that and cannot simply do for the sake of doing. Also we've got this patient blood management Congress coming up in July. So for those who are interested to learn how to conserve darah and not to transfuse unnecessarily,
PBM, patient blood management. Yeah.
In July in Penang.
Yeah. So this is the platform for Vina to advertise on the PBM for us. So Vina, thank you so much.
Yes, please come. You all are interested.
Yes.
I mean, it's important.
How much is that? How much is that? The registration fee?
Oh yeah, I don't know lah, Dr. Sinari. I tak tahu. I forgot already. But I think I think knowledge, we shouldn't put a price to knowledge, kan?
Yes, correct. I agree. I concur with that.
And we have foreign speakers coming and all that. So whatever that you get there would be very valuable. So I think good to at least invest a little bit.
And then one more thing, we have CPG coming up also on PBM, right, Vina?
Yes. Supposed to be
I have the opportunity to read on that as well. It's very good, actually, very brief, concise, and comprehensive. Okay, folks, thank you so much for being with us today. Thank you to the to the organizing committee for this medical webinar, to Dr. Eugene, Dr. Priscilla, and especially to Vina, who's been here with us today for this lovely Thursday evening. And for those who's going to be a weekend, happy weekend. And for those who are going to work tomorrow, happy working tomorrow. Okay, with all that,